Imagine a cardiovascular condition that affects roughly 1 in every 500 people.
Right, which is actually a remarkably high prevalence.
Yeah, exactly. That prevalence makes it literally the most common genetic heart disorder out there. But here's the wild part. Most people who have it experience absolutely zero symptoms when they're just sitting around at
Not
rest.
big at all.
Right. So you could have someone in peak physical condition, an elite athlete whose heart is hiding this fatal structural secret. And it only reveals itself under extreme physiological demand.
Which is terrifying.
It really is. It makes this invisible condition the leading cause of sudden cardiac death in young athletes. So, welcome to today's deep dive. We are going to decode the clinical notes on hypertrophic cardiomyopathy, or HCM.
A fascinating topic.
Truly. Our mission today is to explore how a microscopic genetic typo physically reshapes the heart, why its symptoms act like this shape-shifting puzzle, and how a cutting-edge 2022 medical breakthrough is completely changing the game.
Yeah, to really understand why a seemingly perfectly healthy young athlete might just suddenly collapse, we have to trace the problem all the way back to the microscopic building blocks of the heart.
Okay, let's unpack this. We're talking cellular level here.
Yeah, exactly. HCM is fundamentally an autosomal dominant genetic sarcomere disorder.
Which means you only need one copy of the mutated gene to inherit it.
You got it. And the clinical notes specifically highlight two gene mutations that are the usual culprits here. There's MYH7, which codes for the beta-myosin heavy chain.
Right.
And then there's MYBPC3, which codes for the myosin-binding protein C.
Okay, so if we think about the sarcomere as the heart's basic contractile motor, MYH7 is like the actual motor protein doing the pulling, and MYBPC3 acts as sort of the regulatory brake on that motor.
That is a great way to look at it. So a mutation in either of those creates this severe biomechanical dysfunction. The heart muscle basically goes into molecular overdrive. Yeah, it burns through its cellular energy rapidly. And that localized energy depletion signals the cells to synthesize more protein to compensate.
Which leads to the hypertrophy, the thickening of the muscle.
Exactly. But this isn't that uniform all-over thickening you see in someone with chronic high blood pressure. The hallmark of HCM is asymmetric left ventricular hypertrophy.
Asymmetric meaning it's uneven.
Right. It heavily favors the septum, the wall dividing the left and right sides of the heart. And the notes emphasize this happens completely independent of loading conditions.
Wait, so it's not structural reinforcement from the heart working too hard against resistance?
No, not at all. It's an intrinsic, genetically programmed structural error.
I look at it like a house where the contractor, which would be your genetics, right, decides to randomly build one specific interior wall incredibly thick.
I like that analogy.
Yeah, even though the house didn't need any extra structural support, there's no heavy wind hitting it, but because this interior wall, the septum is now so thick, it shrinks the usable space inside the room.
And what's fascinating here is that the thick interior wall doesn't just take up space. It creates a massive dynamic plumbing issue when the heart tries to pump blood out to the body.
Because it's literally blocking the exit door.
Exactly. The bulky septum bulges right into the left ventricular outflow tract. So during systole, when the ventricle squeezes, blood has to accelerate incredibly fast to squeeze past this narrow passage to reach the aorta.
Right, fluid dynamics. Narrow pipe equals higher velocity.
Yes. And according to the Venturi effect, that high-velocity jet of blood creates a localized low-pressure zone, a suction effect.
Oh, wow, so it's actively pulling on things nearby.
Precisely. It creates left ventricular outflow tract obstruction, or LVO2. And that suction drags the interior leaflet of the mitral valve directly into the outflow tract.
So the valve gets sucked into the narrow tunnel.
Yes, we call that SAM, or systolic anterior motion of the mitral valve. So you've got the thick septum bulging from one side, the mitral valve leaflet pulled in from the other, and they literally smack together mid-beat.
Effectively choking off the blood supply to the body right when the heart is squeezing its hardest.
Which perfectly explains the symptoms. Dyspnea on exertion is the most common one.
Because the body is begging for more blood during a workout, but the heart's exit is slammed shut.
Exactly. The notes also mention angina from microvascular ischemia.
Angina, so chest pain. But wait, without blocked coronary artery.
Right. The thick muscle needs massive amounts of oxygen, but the capillary density hasn't grown to match the bulky tissue. The muscle outgrows its own blood supply.
That is wild.
Plus, we see palpitations like atrial fibrillation and non-sustained ventricular tachycardia, or NSVT, and, terrifyingly, syncope during or after exertion.
Fainting because the brain just abruptly stops getting enough blood flow.
Or because of a fatal arrhythmia.
Right. So if a patient walks into the clinic, how do doctors physically detect this? The notes mentioned a murmur.
Yes, and the physical exam relies heavily on how that dynamic plumbing issue changes based on preload and afterload. The primary sign is a hard systolic ejection murmur heard at the lower left sternal border.
And it changes based on what the patient is doing, right? Like sitting versus standing.
Exactly. The notes use this classic hey VE mnemonic. The murmur gets harder, meaning louder, with a Valsalva maneuver or erect standing.
Erect standing. Okay.
And it gets softer with squatting or passive leg raises.
Wait, so standing up makes the heart struggle more, but doing a squat makes it better?
Counterintuitive, isn't it?
Yeah. It's like, okay, think of the heart's outflow tract like a kinked garden hose. If you pump a massive volume of water through it, which is the increased preload you get when you squat and squeeze blood back to the heart, that sheer fluid pressure pushes the kink open.
Right, it pushes the septum and mitral valve apart.
And the water flows quietly, the murmur gets softer. But if you reduce the water volume, like by standing up suddenly so blood pools in your legs,
The chamber shrinks.
yeah, the kink tightens, the flow gets super turbulent, and the hose gets noisy, the murmur gets louder.
That is exactly the physiology. But since the murmur literally changes by the minute, clinicians need a way to look inside and accurately measure the danger.
Right, which brings us to imaging. You can't just listen to a changing murmur and call it a day.
No, definitely not. The gold standard for initial diagnosis is the TTE, the transthoracic echo. They are looking for a septal thickness of 15 millimeters or greater.
Though the notes say if you have a family history, that threshold drops to 13 millimeters.
Right, because of the genetic risk. But to truly predict the future, they pivot to cardiac MRI.
Because the MRI sees things the echo misses.
Exactly. It measures the wall thickness perfectly, but more importantly, it looks for something called LGE, or late gadolinium enhancement.
Which indicates fibrosis, right? Scarring in the heart muscle.
Yes. The gadolinium contrast pools in the scar tissue, and LGE is the strongest predictor of sudden cardiac death risk. The chaotic scar tissue creates short circuits in the heart's electrical system.
Speaking of electrical, the ECG findings are pretty distinct too.
They are. You see left ventricular hypertrophy, obviously,
Ugh.
but also deep, narrow Q waves in leads I, AVL, V5, and V6.
Because the septum is so massive, the electrical signal moving through it is just huge, and it looks like a heart attack on the EKG.
Exactly.
Yeah.
So if we connect this to the bigger picture, we look at the ACHA 2024 Sudden Cardiac Death Risk Stratification.
The ultimate checklist for whether someone needs a defibrillator implanted.
Yes, if a patient has one or more major risk factors, doctors consider an implantable cardioverter defibrillator, or ICD, for primary prevention.
Here's where it gets really interesting to me. Having HCM doesn't automatically mean you get a device. It's highly specific.
Very specific. The major risk factors include a family history of sudden cardiac death from HCM, unexplained syncope.
Which means they probably already had a dangerous rhythm and just passed out from it.
Right. Also, a max wall thickness of 30 millimeters or more.
Wow, double the diagnostic threshold.
Yeah, it's massive. Then there's NSVT on a Holter monitor, an abnormal blood pressure response to exercise, a left ventricular apical aneurysm, and extensive LGE on that MRI, specifically more than 15% of the left ventricular mass.
That is a lot to weigh. And if they hit those markers, they get the ICD. But even without the ICD, the notes highlight a strict sports rule.
A very harsh reality for many.
Yeah, all competitive sports participation is categorically prohibited in HCM, regardless of whether they have symptoms.
Not at all.
The only exception is if they're deemed low risk and go through an intense, shared decision-making process with their doctor.
Right, because the extreme adrenaline and volume shifts of competitive sports are the perfect storm for those arrhythmias.
So what does this all mean for actually treating the patient day to day? Because figuring out how to medicate a heart that is actively obstructing its own blood flow sounds like a nightmare.
It genuinely turns standard cardiology completely upside down. The first-line medications are beta blockers.
To slow the heart rate down.
Yes. By slowing the heart rate, you give that stiff left ventricle more time to fill with blood during diastole. More blood equals more preload, which, as we discussed, pushes the obstruction open.
Plus, beta blockers make the heart squeeze a little less aggressively, right?
It's exactly, negative inotropy. A softer squeeze means less Venturi suction effect on the mitral valve. If beta blockers aren't tolerated, we use calcium channel blockers like verapamil or diltiazem.
And the notes mention adding disopyramide if the obstruction is still stubborn.
Yes, it's an antiarrhythmic that strongly reduces the squeezing force of the heart.
But the craziest part of the clinical notes is the medication paradox. Standard heart failure medications like nitrates, diuretics, digoxin, and vasodilators must be strictly avoided.
It is a fatal trap if a clinician isn't paying attention.
It makes sense when you think about the mechanics. Giving a diuretic to someone with an obstructed heart is like trying to fix a traffic jam by closing more lanes.
That's spot on.
You give them a diuretic, they pee out their fluid volume, preload drops, the heart chamber shrinks, and bam! The septum and the valve crash together completely. The obstruction gets universally worse.
And digoxin increases the squeeze, which worsens that suction effect. It's the exact opposite of what you want.
So what happens if medications just aren't enough? Say the outflow gradient is severe, like 50 millimeters of mercury or higher.
Then we move to structural interventions, septal reduction therapies. The gold standard is a surgical myectomy.
Open heart surgery.
Yes. The surgeon literally cuts out a chunk of the hypertrophied septum to physically widen the exit tract.
And the alternative is alcohol septal ablation, which blew my mind.
It's an incredible procedure. They thread a catheter into the tiny artery feeding that thick part of the septum and inject pure alcohol.
Inducing a highly controlled, localized heart attack.
Exactly. The tissue dies, it scars down, and it shrinks over time, clearing the outflow tract.
But both of those carry massive risks. Pacemaker.
Which is why the field has been searching for a better way. This raises an important question. What if we could just fix the genetic motor itself?
Instead of just managing the plumbing or cutting out muscle.
Exactly.
Yeah.
And that brings us to mavacamten, which was FDA approved in 2022 from the Explorer HCM trial.
This is the breakthrough.
It truly is. It's a first-in-class allosteric cardiac myosin inhibitor.
So it targets that hyperactive motor protein we talked about at the beginning.
Yes. It binds to the myosin heads and chemically downregulates them. It puts them in an energy-sparing, relaxed state.
Wow, so it stops the heart from squeezing itself into an obstruction at the microscopic level.
Exactly. It reduces the gradient, improves symptoms, and directly addresses the underlying pathophysiology. It's a total game changer for obstructive HCM.
All right, let's wrap this up for you listening at home. HCM is basically a fascinating genetic lottery ticket, a 1 in 500 chance that builds an uneven heart.
A heart that functions totally differently depending on how much fluid is in it.
Right. It creates these dynamic physical obstructions that demand totally counterintuitive treatments, avoiding traditional heart drugs. But now, thankfully, we finally have targeted medical therapies like mavacamten addressing the root mechanism.
We've come a long way from just telling people to sit down and rest.
We really have. But before we sign off, I want to leave you with a final thought to mull over. The clinical notes state that competitive sports are prohibited for HCM patients, quote, regardless of symptoms, unless allowed through shared decision-making.
So to sum it up, hypertrophic cardiomyopathy is basically a definitive clinical primer on pathophysiology we are discussing, and its prevalence is 1 in 500 with thickened intravesicular septum, septal hypertrophy, LV cavity volume reduction, and LV outflow tract obstruction leading to the problem. So this is hypertrophic cardiomyopathy. The problem lies in genetics as autosomal dominant inheritance with MYH7 beta myosin heavy chain and MYBPC3 myosin binding protein C chain mutations with sarcomeric disorder, asymmetric LV hypertrophy, septal hypertrophy, and it is independent of any prior loading conditions. Thickened septum protrudes into outflow tract. The movement systolic anterior motion of the mitral valve leading to the collision of LV outflow tract obstruction through the Venturi effect. Dynamic LV obstruction is the mechanical root of clinical presentation, and there is no obstruction at rest, but on exertion the patient might have LVOT obstruction. Syncope, dynamic LVOT obstruction during or after exertion, dyspnea on exertion, angina due to microvascular ischemia and palpitations, atrial fibrillation or non-sustained or sustained ventricular tachycardia. It is the leading cause of sudden cardiac death in athletes. How would you do physical examination? There is a harsh systolic ejection murmur at left sternal border. There might be bifid or bisphenous pulse, and there may be S4 gallop. It increases with Valsalva or standing. The mechanism is that there is reduction in preload, which narrows outflow tract and worsen LV outflow tract obstruction, and the murmur grows louder when the preload is down, and when the preload is up with squatting and leg raise, there is expansion in the LV volume and widening of LV outflow tract, and murmurs go softener. The diagnostic triad through echocardiogram with septal thickness more than or equal to 1.5 centimeter or more than or equal to 1.3 centimeter, a family history, systolic anterior motion, LV outflow gradient, and diastolic dysfunction are all assessed. With cardiac MRI, further precise wall thickness and late gadolinium enhancement of the fibrosis is the strongest predictor for sudden cardiac death risk stratification. On ECG, there may be deep, narrow Q waves in 1 AVL, V5, and V6 because of extreme septum depolarization, and it identifies severe LV hypertrophy and may record baseline arrhythmias like AFib, non-sustained, or sometimes ventricular tachycardia. Sudden cardiac risk stratification starts with family history, unexplained syncope, massive LV hypertrophy more than or equal to 30 mm, non-sustained VT, abnormal blood pressure response, that is, blood pressure decreases with exercise, LV apical aneurysm, and extensive or more than 15% of LV mass getting late gadolinium enhancement, presence of any of the major more than one risk factors is strongly a candidate for implantable cardioverter defibrillator. Pharmacological therapy, first line beta blocker, which reduce heart rate, improve filling time, and reduce LVOT obstruction. Non-dihydropyridine calcium channel blockers like verapamil or diltiazem, if beta blockers are not tolerated well. In refractory cases, disopyramide is added for persistent obstruction. Avoid nitrates, diuretics, digoxin, and vasodilators in hypertrophic cardiomyopathy because they reduce preload and shrink the ventricle and may worsen LVOT obstruction. Therapy spotlight in Explorer HCM trial, first in class allosteric cardiac myosin inhibitor, directly reducing LVOT obstruction gradient and improving NYHA class in symptomatic hypertrophic cardiomyopathy with obstruction. Surgical myectomy is the gold standard if a surgical intervention is on the requirement, and also catheter related alcohol septal ablation may be done for refractory symptoms with resting or provoked gradient of more than or equal to 50 mm of mercury. The HCM rule of thumb is protect the preload, slow the heart rate, and definitely clear the outflow tract obstruction, and when medication fails, do surgery. All competitive sports are strictly prohibited regardless of the symptoms, and everything regarding competitive sports should follow a shared decision making process. Thank you very much. This is Dr. Asifullah from KMU Institute of Medical Sciences, Cohort. Stay tuned for further lectures. Thank you.